Hi, I'm Isaac Wert. I'm going to be running through my RSI OSCE. Today we're with a patient who's had a severe TBI. He's had his GCS confirmed at less than 10. We'll just confirm that now. Sir, can you open your eyes for me? Not seeing any response to voice, trap squeeze, not seeing any response to pain. So we'll give him a 1 for eyes. Can you hear me, sir? Can you talk to me? So we're hearing some moans and groans. So we'll give a 2 for voice. Can you move? Can you move your arms? So we're seeing some flailing. So we'll give a 3 for motor, which gives us a score of 6. With a severe TBI, we want to be carefully monitoring our patient's saturations. So we've got our SpO2 probe on, making sure that our SpO2 doesn't fall below 94%. So we're ventilating with O2 on a non-rebreather BVM. We're giving assisted ventilations because our patient is performing agonal rests, ineffective breathing. So Abby here is just ventilating once every 6 to 10 seconds. We're also got our end-tidal CO2, measuring his capnography. So we're making sure that
electrodes.
Our CO2 levels we don't want to be too high or too low for our patient. We're also monitoring our patient's blood pressure. We're going to set that up to do a blood pressure every 2 minutes. If our blood pressure, systolic blood pressure comes below 120, we're going to open up our running line, which we have set up just on the side here, through a large bore IV access into the right ACF. We also want to be conscious that because of the TBI and the increased cranial pressure, that can cause our patient to become combative. So we've also drawn up a 10 milligram dose of midazolam, labeled that, and have that ready in case our patient becomes combative. This all occurs because the intracranial pressure increases due to the bleeding, pushing on the brain, which causes a change in brain and neurological function. So we want to make sure also that our mean arterial pressure is high enough to continue cerebral perfusion and cerebral oxygenation to make sure that the brain doesn't become hypoxic.
Connect electrodes.
Because we've called for an R50, we want to go in for RSI. We're going to go through our RSI preparation checklist to make sure that when the ICP arrives, we can go straight into that procedure. So Abby, we'll just run through the checklist while we ventilate there, if that's all right. Can you just read line by line, and we'll make sure that we do everything there.
Cool. So the first one is attach nasal prongs without oxygen.
So I'll just work around you. If you can just make sure we keep breathing, and if you can monitor his blood pressure and his SpO2 sats, that'd be great. Okay. Get those nice and secured. So we want to attach our nasal prongs so that when the ICP is attempting intubation, we still have passive flow through the nasal canal. Okay, what's the next step?
Pre-oxygenate using a reservoir mask at 10 litres per minute.
Okay, so we're using our BVM with the reservoir mask. We're running 15 litres of O2, so we're getting maximum O2 saturation.
And then with PEEP set at minimum of 5 centimetres H2O.
Okay, let's attach our PEEP. I'll just get it on to 5. After your next breath, how about we do that? Yeah. Okay, is that still good? Happy there?
Sweet. So attach ECG, NIBP, and SpO2.
Okay, let's put our 3 lead on. We have our NIBP already on, monitoring his blood pressure because we were worried about the hypertension from affecting our cerebral perfusion. We'll get our 3 lead on so that we can monitor cardiac. Alright, I'll just set this up so we can view our SpO2 as well as our lead. And our CO2. Okay, next one.
Prepare capnography if this is available.
Alright, so we already have our capnography running through our BVM.
Mhm.
We're getting a trace out on the monitor. You can happily read that?
Yep.
Great. Next one.
Position the monitor so that it can be seen leaving space to the right of the patient's head for intubation equipment.
Okay, so we have our current airway management on the right, so let's move that out of the way. And give some space, we're going to need that later. We can move all this down. So there we have an LMA set up as a possible adjunct if we have a failed intubation. Okay, next one, we've got a nice space here on the right.
Gain IV access, preferably in 2 sides.
Okay, so we currently have large bore in both left and right ACF.
Great. Prepare a running line of 0.9% sodium chloride.
We currently have our line set up, spiked and primed, and we're just monitoring our blood pressure to make sure that doesn't dip below 120.
Position the patient for optimal airway control.
Okay, so we've got a towel under here, placing him in the sniffing position. We also have extra towels in case we need to move that alignment.
Place an EGT holder with the strap undone under the patient's head.
Okay. So just on your next ventilation, I'll get you to lift his head up for us. Just be careful of the occiput. So from the side, great. Just slide that under here. Okay, tube holders in place. Just monitor that SpO2.
Ensure suction is working and turn it off.
Okay. Put that suction here on the left, keeping it out of the way of the right. Just make sure it works. Yeah, it's getting good suction. Turn that off and we'll place that under the head.
Prepare a manual ventilation bag with PEEP valve attached if not already in use.
Okay, that's what we're using.
Obtain a set of vital signs.
Okay, I'm just going to go in with NIBP. We've got our pulse and our O2 from that. We've got from our SpO2 meter. We've got our 3 lead giving us a heart rate as well and a rhythm. We can get we're providing resp, so our resp rate is once every 6 to 10 seconds. And we've just got our BP there.
Great.
And it's currently above 120, so we're happy with our line placement.
If possible, update the responding ICP with the patient's condition and vital signs.
Okay, we'll do that. Is that the end of the list?
And then the last one is prepare the area. So if the patient is not in the ambulance, clear the area so there is access to both sides of the patient if possible.
Okay, I'm happy with our space. How about yourself?
Yeah.
Okay. Now I'll just call comms and update our arriving ICP. So I'm going to give him our vitals, our exact location, and our current interventions, as well as any other pertinent information that we have gathered through our history gathering process, such as the height of the fall and the mechanism of the injury, and yeah. All right, that's the completion of our RSI checklist. So we'll hold fire until our ICP arrives, and then we'll perform an advanced airway when that occurs. So our intubation, the ICP will have 2 attempts. So following the first attempt, failed intubation occurs when the tube is not passed within 15 seconds of our last ventilation. So he's going to be using a bougie, which is a rigid or malleable guide to pass through the cords. And this is used because it it's a narrower and more manipulable object than the raw ETT tube itself, so it will help guide the tube past the cords. If after 15 seconds that hasn't occurred, or if after 30 seconds we don't have an appropriate end tidal reading, then we have a failed intubation, and we will return to our last working adjunct for the airway, in this case a BVM with full oxygenation, and we're going to bring that SpO2 back up so that we don't drop our SATs. After the first attempt, the ICP will change something. You might use a different ETT tube or a different method to try and pass the tube. So that's what we'll be on hand for. We also have an LMA there we can try and place maybe after the second failed intubation, as that's a higher level airway control than a BVM. Failing the successful placement of an LMA or a working BVM, we can attempt a cricothyroidotomy, which is a surgical airway where we use a scalpel to enter the airway through the neck. This can be quite useful in patients who have either severe anaphylaxis or have choked on something, because we can bypass that upper airway region, which can become easily constricted. And we've covered the use of a bougie in a RSI. So yeah, our aim is to maintain a high SpO2 and high blood pressure to keep the brain adequately oxygenated before we can reach a tertiary hospital for further care. Thank you.